We have an exciting hour to be discussing a number of points and issues related to the recently published just this week, the SCAI Expert Consensus Statement on the Management of Patients with STEMI referred for primary PCI. We have a wonderful panel of experts that were involved with this document for over the past year that really came together to put together this guidance, and we'll be discussing many of these points. We have Dr. Jacqueline Tamis-Holland, Institute Director of Acute Coronary Care at Cleveland Clinic, Dr. Dawn Abbott, Associate Chief of Faculty Development and Academic Advancement at Brown Health and Cath Lab Director there, Dr. Nitin Barman, Director of the Cath Lab at Mount Sinai in Morningside, Dr. Anna Bortnick, Associate Professor and Program Director and Director of the Interventional Fellowship in Montefiore Medical Center, Dr. Mauricio Cohen, Interventional Cardiologist at the Cleveland Clinic in Florida, and Dr. Selena Yon, Director of Interventional Cardiology at Palo Alto VA Medical Center and an Associate Professor in the Division of Cardiovascular Medicine at Stanford. So again, a very great panel. We're looking really forward to a lot of presentations, but next up, I'm pleased and honored to present the chair of the SCAI Expert Consensus Statement of the Management of Patients with STEMI, Dr. Jacqueline Tamis-Holland. Please, Dr. Tamis.
Thank you, Dr. Sandoval, and welcome everybody, and thank you for joining us. So I'm really excited to talk to you about the expert consensus document. What we're going to do today is we're just going to give a brief overview of the document, and then we're going to go in to give some case presentations that hopefully reflect important points that we wish to make in the document. So please definitely send in some questions if you have on the chat, and we'll try to answer them. Alan, did you want to bring up the slides? So I am going to be your cruise director and take you through the document and just sort of give you the points, so that way you understand the flow, because it is an extensive document. We want to sort of get you familiar with it. So go ahead to the next slide. So this document came up because we felt that there was a real need to guide practitioners on the best way or the best practices for managing the patient in the lab. There are fantastic ACC/AHA guidelines on the management of patients with STEMI, and all of the guidelines on managing patients really are patient-focused and really talk more about the general aspects like medical therapies and post-procedure care, et cetera. But there's little guideline recommendations for what do you do in the cath lab, and that's a lot partly because there really is no great evidence for how do you manage thrombus or how do you manage no-reflow, and partly because the guidelines are really patient-focused, so on sort of the big aspects of care and less procedurally focused. So we felt this was an important opportunity to present a document. We realize that everybody has different ways, and so the flavor of this document is presenting all different ideas and ways to approach things. It's not meant to say necessarily that one approach is better than another. We just really wanted to give you an understanding of the consensus among a group of people who all of whom do a lot of STEMI care, and give you the best idea about how to manage things. You can go ahead to the next slide. So the document starts with cath lab readiness and the initial assessment. Even though that's not literally a cath lab management, this is important and integral for interventional cardiologists and cath lab team members to work together with EMS and EDs to provide the best, assessment of patients and timely transfer to the cath lab. We go on to talk about optimal techniques for angiography, such as arterial access and how best to perform the diagnostic part of the cath. And then we talk about the approach to PCI, and we really focus on a big discussion on managing thrombus and managing no-reflow. We do discuss intracoronary imaging because we do feel it's important, highlighting the rationale for why we want to do intracoronary imaging and the things that you should be looking at for intracoronary imaging. We do have a section on emerging approaches to reduce infarct size, which is really more about future directions. A lot of this stuff is just still currently under investigation. And we end with special circumstances, including and then anatomical subsets and discussion of non-atherosclerotic causes of STEMI. And as I said, we also talk about future directions. So there's a lot to cover, and hopefully you can sort of take a look. And on a Saturday morning when you're just drinking your coffee, go ahead and read this document because it's a good read. Okay, go to the next slide, please. So what I think, one of my favorite things is the consensus key points, which I think are key to this document. It's a long document, there's a lot to be said. And as I said, we really try to give different approaches to care because we realize there's no particularly right way. But the consensus key points are key points that we agreed as a consensus. This required at least 80% of the panel of the authors to vote, and we needed to have at least 75% of the votes to be strongly agree or agree on these points. So really important key points. They really emphasize the importance of certain things that we thought were really critical. This is just an example of the key points we provided for management of no-reflow, but all of the sections have consensus key points. You can go to the next slide. So as I said, we're going to start with the time to treatment goals. These are not new. These are guideline-based treatment goals. But we really wanted to sort of remind people of the fact that it's time to treatment is first medical contact to device. And the first medical contact will depend on how the patient arrives to the hospital. If they go from home and call EMS, the first medical contact is EMS to device time. If they come where they walk directly into a PCI hospital, the first medical contact is when they arrive at that hospital. And if they go to a non-PCI hospital and then get transferred to a PCI hospital, the first medical contact is generally when they arrive at the non-PCI hospital. So we really want to emphasize those time to treatment goals. You can go on to the next slide. And then within that, we really go on to discuss the importance of timely recognition of these infarcts, collaboration and coordination with EMS and your transferring hospitals, and the key things that improve timely reperfusion. So we emphasize the need to for EMS presenting patients to give pre-hospital activation of the Cath lab. We don't mean just notify the ED that the patient's coming in, but let the Cath lab know that the patient's on the way. We emphasize that it should be a single page to all Cath lab team members, not just discuss with the interventional cardiologist and then have them call their team members, one single page. We really think EKG transmission is key, especially if it goes directly to the Cath lab team members. We focus on emergency department bypass in appropriate cases. There's really no need to stop in the ED, transfer stretchers, do a repeat EKG when it's a clear-cut STEMI. There's nothing you're going to do in the ED that you can't provide in the Cath lab if they're a stable patient. And then finally, we do emphasize the need to have staff either in-house or, ideally within 20 to 30 minutes of travel. Go on to the next slide. So we, as I mentioned, we do talk about sort of optimal approaches for, diagnostic angiography, and we want to emphasize radial artery access. We know that it's a class 1 recommendation in the revascularization guidelines. They do state that it should be done it's a class 1 if it can be done in systems in places with radial artery expertise. We feel that at this point in time, everybody should have radial artery expertise, and we emphasize the importance of radial artery access. But we also do want to emphasize that there are situations in which femoral artery access is necessary, and we go on to discuss those situations. Next slide, please. We then focus a lot of attention on managing thrombus and no-reflow, which will be some of our talks on the presentations we provide. And in this section, we talk about how you would approach a subtotal occlusion or a total occlusion with thrombus, and the steps that you would take and the considerations you would have for whether you would go with direct stenting or just balloon angioplasties, or in the situation where you have a very large thrombus burden, the situations where you might want to consider intracoronary vasodilators, thrombectomy, or intravenous or intracoronary antiplatelets. Go ahead to the next slide. Finally, we really love this part. We talk about intravascular imaging. It's one thing to say you use intravascular imaging, but it's a reminder to say, what are we using with this imaging? We're getting an understanding of the proximal and distal reference diameters, the type of plaque and the lesion length. And then we're using post-PCI, we're using these imaging to ensure that we have optimal stent opposition and good expansion. Go to the next slide. So as I mentioned, we have additional sections on special circumstances, such as how do you approach cardiogenic shock, post-lytic patients, patients with multivessel disease, when you have an infarct involving a coronary artery bypass graft, and when you have stent thrombosis. We go on to talk about anatomical considerations, like what do you do in bifurcation disease, calcified lesions, and aneurysms or ectasia. And finally, we talk about non-atherosclerotic causes of STEMI, such as epicardial coronary vasospasm, SCAD, thrombosis, and MINOCA. And so, that's basically it. We're going to go on to talk about some really great cases. We have some really great cases lined up for you all. But I really did want to give a big shout out and a thank you to all of my co-authors, for their amazing insight and direction, their knowledge and expertise in caring for STEMI patients really, really helped put this document together and make it a solid document. But importantly, I also want to, and this is just a picture of some of our co-authors. This was in July when we made some last minute changes to the document. We were all together, but not everybody's on this picture. Sorry, this is not all the co-authors. But I really want to give a big shout out to SCAI leadership and SCAI. They recognize the need to educate the physicians and to really provide us as a clinician with practical information. And by allowing us to be able to produce these documents and give us the support and the direction and the leadership to get these documents done, it's how we're able to provide this to you as the clinician. So thank you very much.
Thank you, Dr. Thames Holland, for that wonderful presentation and overview. I will just echo that your point about the consensus key points. There are just all these areas that there's just not enough randomized data or trials yet are common clinical scenarios that we see every day in the Cath lab, that there is the need for some information as to how to take care of these patients. And I think, again, this is an extensive document addressing on all of these areas, but really provides those key consensus points along a number of very experienced interventional cardiologists from SCAI that provide some guidance in these areas. So again, really congratulations. And any comments from the panel before we move to some of the presentations? I will be of any input from anybody.
No, I agree that this fills a gap that the guidelines don't fill because it's more practical and it's issues that we face and decisions that are difficult and have to be timely. So I'm hoping this will help some people, give some options, treatment options when they're treating patients with STEMI.
Dr. Cohen, I know you've been involved in a number of guidelines and documents across your career. How do you see this document help interventional cardiologists in our community?
I think it's a very practical guideline because we all train in different institutions, and then they're like inbred practices, and this allows us to harmonize. And there's things that this group were doing and that I was not doing that made lots of sense. And then I learned from this group and writing this document. So I think it's a great resource to harmonize practices and then to read it, do a journal club, to do it, to go through Cath conference, to do like what we're doing now. Grab one STEMI case and then dissect the case and go through all the aspects that we discussed in the document. So it's a great initiative, and I applaud the SCAI and thank you so much for being here.
So wonderful. So again, we have a series of cases that I think will really invite discussion about many of these key consensus points and really educational highlights. So we'll start with the first presentation. Again, we've introduced all speakers, but again, a pleasure to introduce Dr. Dawn Abbott, who will be speaking on a case of refractory no-reflow. Please, Dr. Abbott.
So Dawn, you're on mute.
You're on mute, Doctor.
Okay, now can you hear me? Good.
Yes, we can.
Took a couple of mute buttons. Okay, so this is a 53-year-old smoker. 1 hour of chest pain prior to first medical contact. When EMS arrived, she received aspirin and a 12-lead EKG was transmitted. Those documents, the 12 leads go to the command center at Rhode Island Hospital and also to our cell phones. And so we were activated pre-hospital on her arrival. The STEMI team was already on the way in. The fellow was called down to start stabilizing the patient and consent. In this particular case, given the rapidity at which she got to the lab, she got prasugrel in the Cath lab. And we can talk about some of the preloading strategies, but that's what this patient had. Okay, so the first question, I guess we can ask the panel is, how many people are getting the EKGs transmitted and pre-hospital, and can we discuss the pros and the benefits of that? So I don't.
So what we'll do is, I think for this question, we'll just go down the panel. I'm going to start at the top, just in order of how I see these pictures. So Dr. Barman, how do you get EKG transmitted to you as the interventional cardiologist, and how is it transmitted?
Yeah, so we do for patients that are interacting with EMS in the field. That field EKG is routed through the FDNY command center. And if it's deemed to possible or probable STEMI, the activation will go out, and it comes by way of EKG. By email. So we get an email PDF of that coincides with the activation. So we, just log on to our email and get the EKG. So we often get the EKG before we get a call. So we don't even know that there's a STEMI other than having received the EKG. It works well. And we have to turn it over every year with new fellows and new staff, but it works well.
And Dr. Bortnick?
Well, we're also in New York, so we have the FDNY system that Dr. Barman was talking about. However, the EKG is not only just going to our email, but it's also coming through a commercial application. So we're also able to visualize it directly on the phone and interact with the commercial application. So you can actually respond to whether you got it. You can actually text message with other individuals who have the same application. At one of our sister hospitals, we're able to do that. So there are other commercial applications that you could be using.
That's fantastic. Yeah, that there are some great applications, but there's one specifically that works with that particular EKG transmission. Dr. Abbott?
Yeah, so we have a system called LifeNet, and it comes to our cell phone. So when you're on call, usually you have your notifications on that you've got an email, but also when it gets to the command center, they page you in case you didn't look at it, and that way we're coordinated.
Great. Okay, so I think a lot of us are using the LifeNet because that's the one you're referring to, Anna, right? Not Dr. Bortnick, right?
Yes,
Dr.
yes.
Dr. Sandoval?
No, same, not much to that, except that we do have, one of our colleagues involved in this document, Dr. Tim Henry, was very involved in many of these things, but we have a long-established, what we call level 1 STEMI system, in which all these approaches discussed apply, but we also do have, there's always a cardiologist on call 24/7 available to evaluate all these cases, and we'll be able to review and triage these EKGs as well.
Terrific.
Dr. Young and Dr. Cohen.
Sure. Stanford has a similar system. The pre-hospital EKG goes to 3 people, the attending on call, the interventional fellow, and the charge nurse.
And Dr. Cohen.
For us, a similar thing. So we get the EKG gets from the fire rescue to the ED doctor, and then there's a general single activation, and everybody comes. If I want to see the EKG myself, I talk to the fellow, or I can go into Epic and look at the EKG done in the hospital.
Oh, so for you, you don't get it directly to your email?
I don't get it directly to my email, no.
Got it. Okay. I think we can get that to you. I'll talk to you offline about that. Okay.
All right, I'll keep going. Okay. Okay, so fortunately with the antiplatelet therapy in heparin, this patient had reperfusion, and you see here it's near TIMI 3 flow. She was still having ongoing chest pain. The ST segments had improved but not resolved, and you can see here the preferred radial approach. In our institution, we typically start with the culprit artery first, guiding catheter, under the majority of circumstances outside of shock, and that's something maybe we can talk at the end of the cases, but in this case, this appeared to be in line with the culprit ST elevation. So the operator proceeded with intervention. So I guess we'll stop again and maybe ask a few people. So it's a large artery with an extensive plaque volume. Not a lot of visible thrombus, but with the STEMI, we know there is a lot of thrombus with the atheroma in the plaque.
So
Can you show the picture again?
I'm going to start by asking just one person, Dr. Barman, why don't you tell us, what would you do here?
Yeah, I'll start by saying, other than the anatomy of it being a large, positively remodeled lesion, there's not a lot of features that would make me overly concerned about no reflow. And I think that's an important point, that it can kind of happen anytime. Specifically, a very early presenter, what looks like TIMI 2-3 flow to start the case. The fact that the STs hadn't resolved with this first angio implies maybe some antecedent kind of de novo embolization, but I wouldn't be overly worried. I would, in this case, many cases, I would just go right to direct stenting. In such a case, I would probably image here just because of the parameters of the vessel are so kind of out of the norm, I would say, that I'd want to really understand length and diameter such that I could minimize potentially subsequent steps like post-dilating, et cetera. But yeah, no, it's fun to see this vessel open when you get to the lab.
Yeah, terrific.
Anybody here would do anything differently besides either balloon and stent or direct stent? All right, go ahead, Don.
Yeah, I think just to make not a counterpoint, I think it's a great vessel for direct stenting, but some people already have like a small balloon prepped in a wire just to kind of shut the clock off, the door to balloon time. So I think if you were to approach this with a predilation, it's more of like an undersized, low pressure, shut the clock off, make sure it's dilatable, than rather taking a huge balloon in here and potentially causing no reflow early in the case. So, but in this case, what the operator chose to do was do intravascular imaging because it was such a...
Dr. Abbott, can you stop for 1 second?
Yep.
Dr. Bartnick you had a comment?
I do, and that's one thing that we brought up in the consensus statement, was whether or not we should be getting a full angiogram before we proceed to the culprit.
We will be talking about that.
That's definitely something that we might want to get back to here. And then to point out, there's a comment in the QA there that we should also address.
Okay, great.
Terrific. Yeah, like I said, our practice at our institution is generally go for the culprit vessel. There are exceptions to that, of course, but that was done in this case, and IVUS was done. And in this case, the vessel was direct stented. I think it's a 4.5 or a 5.0 30 drug-eluting stent deployed at average pressure, like 12 to 14 atmospheres. You can see the positioning there with respect to the marginal branch. And then the patient basically has near asystolic arrest following that placement. Okay. So that's the point. Be ready for the no reflow. So before you even think about what vasodilators you're going to deliver and how you're going to deliver them, you have to stabilize the patient's ABCs. This patient was, underwent chest compressions, epinephrine and intubation, peripheral epinephrine. And then I guess once you've stabilized the ABCs, back to what are you going to do?
So I'm going to ask Dr. Sandoval to give us his input on what is the most important step in the management of no reflow.
Absolutely. No, so this is where I really, and we've worked on this document, right? This is SCAI-TV document now for quite some time, but I reread it today during during my flight coming back to Minneapolis. And I will admit that there's a lot of information, but I guess, we should all read the boxes that Dr. Tanis Holland mentioned, I think are really key because underscore what we need to do. And the box is clear that what we need to do is to really maximize that corner perfusion pressure, reduce LBDP, give our arterial vasodilators. Which one goes first, which one goes second? I guess I can let the panel decide, but again, you're thinking here, if you, as you pointed out, your patient is intubated, decompensated, you want to improve that pressure, reduce LBDP, you're thinking about potential mechanical or circulatory support. And again, everybody will have their favorite sort of cocktail, whether that's, like cardipine, adenosine, epinephrine. Everybody can speak about different things, but again, I would really underscore that table with the key points.
Terrific. Anyone
Just
else?
one comment, because Dr. Henry unfortunately couldn't be on the call, but he asked me to send his sentiments. He really wanted to emphasize that in his experience and based on newer data, there is, as Dr. Abbott had already pointed out, there is definitely some evidence to show that you have potentially less no-reflow with early administration of aggressive antiplatelets. And so he wanted to emphasize the importance, even though the trial data is a little loose in terms of the benefits of upfront antiplatelets. In his own experience and in many of our experiences, we do see less no-reflow with upfront antiplatelets.
Yeah, and this case is interesting because we were so fast because of the pre-hospital EKG, and the patient didn't get loaded until they're in the cath lab. They got a potent P2Y12 that would take effect within 30 minutes, but I'm sure that stent went in less than 30 minutes. So, but given the lack of clear angiographic filling defects, I think it would be unusual for operators to have chosen to start this patient on, say, like integralin or a 2B3A inhibitor. We could ask other people, but so this is why, it's not a perfect system. You're right, our data doesn't even support it, even pre-hospital, P2Y12 maybe, but we're loading so close to the time of the procedure. And so we do need more studies for, potentially these subsets of patients where maybe something intravenous would have helped, but unclear, of course. So this is just a brief cartoon to explain there are just so many factors that play into no-reflow. It's not just the plaque burden and it's the thrombus burden, and it's not just the upfront loading, but it's a lot of things like was already mentioned, the duration and extent. So we know the late presenters are generally going to have a lot more organized thrombus, and this patient was an early presenter. This is a very large vessel. That is a predisposing factor. And then things like that we can't know right off the bat, like their glucose status, if they come in hyperglycemic, what is their A1C, did they get high dose statin prior to coming to the lab? We don't have time for a lot of these things, no preconditioning and some genetic variability. So these are all coming into play, and they're really, a lot of it's outside of our control. I think the other thing I just wanted to mention, and this is an old study from what's called the dynamic registry, which a lot of us know it's a historic registry of PCI, but basically once your patient gets no-reflow, it puts them in a category of high risk. Immediately they have a higher risk of shock and heart failure, reinfarction, and mortality. So yes, the more we understand how to prevent it, the better, but there are certain cases where you just don't predict the highest risk. And if you look at all comers in STEMI, and the risk is like 5 to 7% and lower in NSTEMI and very low in other situations. So, again, this is just to show it's not a benign phenomena when it happens. And again, we talked a lot about the prevention, therapeutic anticoagulation, making sure your ACT is therapeutic, aggressive antiplatelet therapy. If your ER is going to give high dose statin before you take them, getting acute glycemic control, direct stenting, not oversizing stents. And then there's just like a lot of other question marks, right? Like pre-treatment with vasodilators, the thrombus aspiration hasn't panned out as helping with no-reflow, deferred versus immediate stenting still isn't really been like a practice is accepted or studied well enough to accept. Of course, deferring stenting when you don't have good flow is always recommended, but not as a routine strategy. So, and then once it happens, the distal delivery of different drugs, if you need to bail out with a more antiplatelet therapy, LV unloading, and supportive care. So we touched upon most of these. So what happened with this patient, You can see she was resuscitated. She was intubated. She had a TVP for bradycardia. Ultimately, she did have some delivery of intracoronary epi via a dual lumen catheter. She was added on GPIs, and she had a balloon pump to increase her coronary perfusion pressure. Fortunately, once she regained a rhythm, she was not on any Levophed or vasopressors, so a balloon pump was chosen in this case for coronary perfusion rather than, say, something like an Impella. So this just gets back to our main points about, deliver those vasodilators to the distal bed and manage the coronary perfusion pressure. In this case, we achieved that with the balloon pump. So, and that about wraps up my case. So I'll unshare, and any additional comments can be shared by the panel.
So Dr. Abbott, thank you so much. That was an excellent presentation. Dr. Bortnick, I know you want to talk about the arterial access. We were going to talk about it later, but why don't we have you sort of tell me what you do and what are the pros and cons of each, and what is your approach? So not arterial access, I meant to say use of the
Right.
First non-culprit.
Angiogram versus not, right? Yeah. I'll tell you why sometimes it's useful, because in this scenario, for example, you see the RCA and you go for the RCA, but with inferior MI, sometimes the culprit is the circ, and you can be fooled. If there's severe disease in the RCA, you say, oh, there it is. But then you might notice that actually there's a culprit in the OM, and you ended up with the non-culprit vessel stented, which, you'll go and deal with the other one as well. The most important thing is that you recognized it. The other thing that happens is sometimes someone has severe multivessel, and what you realize, or distal left main, what you realize is maybe you're dealing with something surgical and kind of an acute on chronic process. And so then your thinking might change. And you might decide, well, if I, for example, diurese or stabilize the patient, maybe this person really is a surgical candidate. So that's why I say, look at the scenario, but think about whether or not a full angiogram might help you think about the case differently.
That's a great point. And again, our document really poses not what's, in a lot of these scenarios is no right or wrong. So I love the aspects of why you want to do a complete angiogram. I generally am a component of that, but I do believe otherwise in certain situations. Anybody here not do the complete angiogram first, go up with the guide? Well, Dawn, Dr. Abbott, you just said it. Dr. Cohen, can you tell us what your rationale is and why you go up with the guide? You're on mute.
You can shave off about 10 to 15 minutes, and that can make the difference. I understand that that's not a reason, but we are under lots of scrutiny when we're doing these cases, because these cases get reported. Second, if you have an occluded vessel, you're going to open it anyway, whatever you find in the left main. And maybe the strategy to opening it may be different. Maybe you may just do regular plain old balloon angioplasty, but most likely you're going to open it again. When the EKG is unequivocal, I think it can be equivocal in the scenarios that Dr. Bortnick mentioned, but when it's unequivocal, I think going for the culprit, going for the kill, getting it done, the patient ready, and that's fine. Then if you stent the wrong vessel, it's happened to me once, then you can do the other vessel. I mean, the complete trial and all the other trials with multi-vessel PCI endorse that practice. I mean, whether you defer or not, that's a different topic. And finally, it's happened to me only once that there was left main disease after I stented the right. But I mean, those scenarios are very uncommon, and I think you can shave off some time by just going to the culprit.
Yeah, I think there are certain circumstances like cardiogenic shock or late presentation where you just need the information. You might even be putting an MCS first, or you might be doing a right heart cath first. Like, there are certain circumstances, but yeah, I think in 20 plus years, I think I've maybe regretted it twice in that scenario where you think the right's the culprit and there's an occluded vessel on the left and you've wasted 20 minutes. But so I'm extremely cautious about, if there is TIMI 3 flow, shoot the other vessel under certain circumstances. So I think you just, A little bit, you're hedging your bets. It would be interesting to do a strategy trial to see if people's decisions would change with one strategy versus the other. But in my experience, your strategy doesn't change. It may also do with your institution, because our surgeons, even if there's the severe left-sided disease, if they had a right-sided event, in most circumstances are going to want that patient to wait 4 weeks before they undergo elective surgery. And if it's can't wait that long, they usually undergo second PCI.
Yep. No, I agree. And actually, there was a trial showing shorter balloon times in this case, but the strategy trial looking more at clinical outcomes, I think would be important. Dr. Sandoval, I see you have a comment and you're ready to take over for the next case. So I'll let you take over and give your comment.
Yeah, we probably need to move on, but I was just going to add a couple of very quick points. One is because thank you to Dr. Bortic for making that observation. I would say that from the document perspective, I think, and Dr. Tamis Holland, I know that we have discussed this, is that the timing clearly, as you can hear from the panels, there's opportunity for operator preference, but they just said the complete angiography needs to be done because some people may want to just fix the culprit, or maybe sometimes, let's say, grafts or something else, and not do a full total complete angiography, whatever the timing is. So again, a complete angiography. And the other very practical point, again, I think I like going with the guide up front, but some people could argue that, let's say you have a Shepherd's Crook super tortuous RCA, and if you do the diagnostic first with that, then you say like, hey, pass me an AL1, a very supportive guide, so you know what you need from that information. But let's move on. Dr. Tamis Holland, do you want to introduce the next speaker?
Our next speaker is Dr. Selena Young, and she will be speaking to us about managing large thrombus. Is that correct?
Yes, that is right. Thank you. Okay, so this is a case of a large thrombus burden in STEMI. I will start at the beginning of the story, which was pre-STEMI. It's a 59-year-old man who was otherwise healthy, who had presented with 2 months of chest pressure. He had a high sensitive trope of 1500 and this EKG on the right side with some T-wave inversions inferiorly, some peak Ts, and he was referred for Cath. His EF was low normal with some basal inferior wall hypokinesis. Here is the first shot of the right coronary, which only fills partway there. And here is the left side, and you can see some robust collaterals from the left to the right, distal right. So wire is put down and, a little bit more flow, but you can see a lot of thrombus in there. We'll pause for a question.
So just to jump in, because I think it's an interesting coincidence. We just talked about this issue about guide selection, and I see you had a diagnostic there up front, and then seems like you had an AL1 immediately afterwards. Just curious. I mean, like, were there any particular features here that you saw, I need more support?
Yes, well, so in this case, the patient presented with an NSTEMI, so it's more traditional that we would go with a diagnostic rather than the guide. And it did look up front that it was going to be a challenge. So having more support and having sort of the wisdom of seeing the diagnostic and then pulling a guide that had more support, I think was helpful in this case.
Dr. Abbott, any thoughts on how you would tackle this case here? You're mute.
Yeah, I mean, it'd be interesting to see how Dr. Young's team managed it, because obviously it looks challenging for the, and she set up, I think the key is setting yourself up for success. I think when you see a difficult road ahead of you, you don't want to be escalating and escalating and escalating. So generally I tend to have a strategy where I am upfront, better guide support upfront, using guideliners or microcatheters or equipment that can be escalated quickly without a lot of exchanges. So, but that's my approach to
Can you play the angiogram again, Selena?
Oops. Maybe I can. Here we go.
Jeez.
I might add a point on the guide selection beyond support. I mean, I think we all recognize this is a large preformed thrombus, and thrombectomy may be involved. And And I think the document highlights this a little bit, that some of the technique in doing thrombectomy is very relevant, and one of which is making sure the guide is very deeply engaged, such that when you extract the thrombus, potentially the risks of losing that thrombus into the ascending aorta is minimized. So I think the guide choice, for a number of reasons, is wonderful.
Yeah. I mean, you'd have to know how the wire felt going through to make sure you're in the right place, rather than dealing with distal injections, et cetera. Sometimes imaging up front would be really helpful to understand the extent and distance and the size of this vessel.
Great points. Okay. So we used a semi-compliant balloon and then did go ahead with manual thrombectomy with the priority 1. No clot was retrieved, however, and the decision was made at this point to defer stenting. You can see a trickle of flow getting through there.
I mean, fortunately, with the end STEMI situation, the patient was probably stable or not
Yeah,
experiencing.
stable, and we saw that robust collateral coming from the left. So the patient was placed on integralin for 48 hours, dual antiplatelet therapy, including ticagrelor. And the plan was to bring him back with another angiogram, and the plan for stenting in 48 hours. This is what it looked like when he came back.
Maybe before Dr. John,
Yeah.
maybe it's a question. Can you go back to the angiogram with the thrombectomy? I think Dr. Tamis Holland, just interested in your approach here. I mean, like balloon, manual thrombectomy, mechanical aspiration. Any thoughts on this, Dr. Tamis
It's
Holland?
interesting. It's definitely a hard call, and I don't think there's going to be a right or a wrong answer. This is why it's good I can answer this question. I think you have the luxury in a non-STEMI of stepping away. But let's say this was a STEMI and the patient still having ongoing chest pain. I actually think, your guide is really far down there. I would really like to try some more aspiration thrombectomy there. Or, the other thing is, and, sometimes this does work. The artery is very big. And if you can just restore some flow to it with a very low pressure, small profile balloon, you're getting some flow in there, and the body's intrinsic fibrinolysis can potentially help there. But I probably would use aspiration here.
Yeah, I think I would go for mechanical thrombectomy because the volume of the clot is so large, and maybe use a continuous aspiration, because I think you just lose the ability to, the manual aspiration is fairly limited in the amount, and that you might have more risk of embolization. The other option, I mean, if you IVUSed and you had a good landing zone, very high risk for no reflow, but again, sometimes trapping the thrombus behind a stent, a well-sized stent, is an option.
I agree. You definitely want to do a continuous aspiration as opposed to a.
Any comment on intracoronary pharmacology?
Nitin, Dr. Barman, I know that. Let's hear what you do, because I know what you do.
I've been known to give almost 5 figures of sodium nitroprusside in a single case. So I think it's a tough case, and I think we're all would be concerned about the implications of manipulating this lesion, this thrombus. If I were to, I think deferring, if a patient's stable, recognizing that harm can be done to the established collaterals is really thoughtful. If we had to act, or we felt compelled to act, I would definitely put something distally and kind of pre-medicate, pre-treat before any of those things. And I do agree with Dr. Abbott. I would do something pretty active thrombectomies. I would have started with manual thrombectomy as well, but I would have escalated if I was going to continue to act on this lesion.
Would anybody use an angiojet?
Yeah, we're using angiojet, but my understanding is that that's going off the market.
Yeah, we don't have it in our lab anymore. I think since we've gotten the mechanical system, we've been using that.
No, talking about things going out of the cath lab, do you all have eptifibatide?
Yes.
I don't think we carry eptifibatide anymore. We may have trofiban.
Yeah. Well, Reapro's been off the market for a while, so it's one of the small molecules only.
Dr. Young, do you want to show us what happens next?
Sure, yeah. And I think it was because the patient was stable and STEMI, not a STEMI scenario, that they had the luxury really of bringing him back. This is what it looked like, though, when he came back.
Did you shoot the left? Are there good collaterals?
Oh yeah,
I
did you
mean,
see in the beginning there were gigantic
Yeah,
collaterals?
that's
Yeah,
right.
so I mean, basically, you would say the whole PLPD system,
Yeah,
which gave us this. That was the benefit in this scenario,
exactly.
and probably why the patient was so stable, to be honest.
Exactly. Yeah.
So a couple stents were laid down, large diameter 4 and 5 in the mid to distal vessel. Post-IVUS showed
Like Dr. Abbott was saying, so direct stented, you just went down and direct stented this?
It was they had used a semi-compliant balloon before, so it wasn't completely, direct stented. But all this opened up pretty nicely, and IVUS showed an MSA of 12. There was, as you can see at the very distal edge here, residual thrombus there. But the patient was stable. There was good flow down the vessel. I'm curious at this point what you guys would have done.
Probably more thrombectomy, mechanical thrombectomy, or low pressure balloon and a lot of anticoagulation.
Yeah,
Just to
I
make
know
sure
what
that there's
happens
good flow.
next, but I would probably have left it alone, said you got great flow, looks good, give some IV GPIs and call it a day. But sorry, I didn't mean to interrupt it.
Yeah, I think it's just hard because you worry about stent thrombosis if there's not good outflow. And it looks like it's probably just propagated from the distal edge of the stent. So I think I would have tried a mechanical aspiration.
Yeah, so we remember anecdotes, and of course, this is some of the challenges in these areas that sometimes there's not, just much to guide. But I agree that this is it would be very tempted to do additional thrombectomy. Just literally recently, not long ago, I had a similar case, mechanical thrombectomy. We really sucked out a lot of clot. Did PCI stenting. We thought it had a good result. It's still a little bit of clot. Came back not late afterwards with stent thrombosis with full clot. Yeah. So all right.
Oh, well, and this is what happened. So he went to the PACU and a few hours later had a post-procedure VF arrest. He was resuscitated with DC cardioversion. You can see now he's having a STEMI with the inferior ST elevations, reciprocal changes, and this is what it looked like. Just proximal to the stent there.
So, Dr. Young, the thing is that the integrity of the distal circulation was okay because it was perfused by collateral flow. Now you open antegrade, and now you open, all these clot and debris to go downstream.
Yeah.
So, Dr. Bortnick, any thoughts on what to do here?
Well, I'm curious about this lesion that's a little bit upstream of your stent as well. I think you should image this and see if there's any identifiable cause, but it's possible that what's upstream is actually more severe than you think angiographically. You may notice that if you IVUS or OCT this.
In this case, wasn't clopidogrel or ticagrelor? What was your antiplatelet agent?
Ticagrelor. So first, they took a semi-compliant balloon and inflated right at the lesion area, and then aspiration thrombectomy with penumbra and got out some fresh red thrombus, and kind of looks at the end of that back to where it was before. And the decision at this point was to continue the patient on 48 hours of a heparin drip, integralin drip, and continue the aspirin ticagrelor. And that happened, and after that was over, the patient was chest pain-free the entire time, no VF, and was actually discharged home on DAPT.
I like Dr. Bortnick's point, though. I think whenever you have stent thrombosis, it's really important to do intracoronary imaging because there could be a hematoma or something you're not recognizing based on the angiogram, or maybe your stent is not really expanded well. I think even though it looks angiographically well expanded, I would have imaged just to make sure. And then the question is, I'm sure that half the people may have gone ahead and done some additional treatment of the distal thrombus, and I'm sure half would not. But this is why the document was written, because it is so difficult when you're making these decisions. A lot of times you don't have someone else around, you don't have a partner around, it's off hours. And so I think if you have TIMI3 flow and it's unclear what the next step should be. There's not necessarily of harm of waiting until it can be reviewed with multiple people, because you can always bring the patient back. But I think in this case, imaging would have been nice.
It's interesting. They did do imaging after the stent was originally deployed.
Okay.
And that's when they got the MSA that looked good, the stent looked good, and then, you know, a few hours later was when the patient had the arrest. And then they did not do a second IVUS when he came back with the STEMI.
Yeah, I guess they just figured
Could
it
have
was
argued for another.
right. Or it could have been just the outflow problem.
Yeah. Well, that was a great case. Thank you so much, Dr. Young.
Sure. I pulled up here just, you know, the total in the TASTE trials, just as a reminder of these 18,000 patients who were randomized to thrombectomy or PCI alone and didn't see a difference. And in fact, there was a small increase in stroke in the total trial. And so that led to the, you know, coronary revasc guidelines giving a 3 recommendation for no benefit for thrombectomy. And I think this is kind of where the key points for our document really fill in the gaps, because in bailout situations, aspiration thrombectomy would be an acceptable treatment strategy. And of course, parenteral or IC antiplatelet agents could be used as well.
All right, thank you so much. I think we're going to skip this, so we have time to go over to Dr. Cohen's presentation. You're going to be on fast forward here.
Okay. Perfect. Can you see my screen?
Yes, now we do.
Okay, hang on one second. Let me just. Okay, so you're seeing my large screen, right? Okay,
Yes.
perfect. So let me start. So this is a case that I did a few years ago, and so this is a 51-year-old man that had a stent 3 years before presentation. Because it's been 3 years, his doctor told him to stop taking clopidogrel. At very early in the morning, he comes in with 1 or 2 hours of chest pain. The pre-hospital EKG shows ST elevation in the anterior leads. Patient receives in the ER at 6 a.m., treated with morphine. Ticagrelor 180 and transferred to the Cath lab at 6:15. So the first question here.
So we've already discussed this. All right. So why don't we just take the opportunity? Actually, why don't we have you go forward on this? Because it's a great
Okay,
case.
perfect. Yeah, we discussed this. So in this case, we were using an Ikari. It's not my favorite guiding catheter, but you know, I was testing the Ikari. So Ikari IL 3.5 or Ikari IL 4, but it's a left coronary that allows you to engage both vessels. So I engaged the right first because it wasn't going to take much longer. It's only one view. So then you flip the catheter to the other side, and you get a good view. So my views for the we didn't talk about that. I usually use an AP caudal and an AP cranial. That will give you a great view of what's happening with the circumflex and the LAD. Here's the LAD, and you can clearly see here that there's the LAD is missing, and there's an empty stent, so stent thrombosis. So we go here with a standard regular wire, so it's a workhorse BMW wire. We are able to traverse the lesion. Then we felt that there was enough thrombus to require thrombectomy. We went with an export catheter, and this is the result after the export catheter. So then we pre-dilated further with a 2.5 balloon just to establish.
Mauricio, I'm going to,
Yes.
Dr. Cohen, sorry, I'm going to just pause
Maurice is
here.
okay.
Because I'd like to actually, this is one of the key points of this case, and I didn't get a chance to stick a question in there, but I'd like to sort of ask, let's ask Dr. Barman. So now you've got a STEMI with stent thrombosis and a bifurcation lesion, and and a diagonal with some disease. How would you, do you protect the diagonal? Do you do provisional stenting? What are your thoughts here?
I mean, I'm a minimalist for sure. I think certainly because it's a stent thrombosis and because it's a STEMI presentation, I would want to be avoiding stenting a side branch or even interacting with the side branch. So I would only do so if I was concerned that it would close. So I think in this case, and you know, I've had the luxury of seeing the slides, I would probably have pre-treated it. You know, even though you have an unbelievable result with the thrombectomy, and I think it speaks to the fact that there are individual cases where there's value there. I still think there's probably a great deal of thrombus in that area. There's a 50% osteo lesion. I think it's a favorable angle. So, you know, not doing it is reasonable. I think you ultimately be able to cross, but I probably would have done either atherotomy, as there's kind of a fibrotic ring there, or even just a PTCA prior to stenting across.
Okay, so those are good points. I mean, we felt here that the vessel is not that big anyway. It's 2.5, you know, enough to consider this a bifurcation, right? But given the TIMI 3 flow, so we pre-dilated here with a 2.5, and then this is a result. So at this point, the patient shows non-accelerated ED ventricular rhythm. He's super stable, so that's a sign of reperfusion here. Patient is happy, feels great. Patients fall asleep. He hasn't slept all night long. So now, and this is how do we approach the lesion. So now we have to finish it up. We have to stent it. So the options are, do you just stent across? Do you do any of the dedicated techniques like TAP or DK crush or provisional stenting? So I don't know, how would you approach this? You call the panelists and Jackie.
Yeah, so Dr. Barman gave us his input. Let's take one more comment. Dr. Young, what would you do here?
I would still take a provisional approach, maybe put a wire in it, but just see how it goes and decide after if there's poor flow.
Okay.
Yeah, I'd just like to comment that even though there is a 50% lesion in the side branch, it's relatively focal. I think this is an excellent lesion for a provisional strategy. And as it was already brought up, we really get concerned about two stent strategies in a thrombotic milieu. It certainly increases the risk. So I do agree with having a wire there, even though the risk of acute complete closure is low. It does potentially maintain some flow and identify the vessel origin if that were to happen.
Okay. Well, so I heard all you said about IVUS, and this is a stent failure. So I think you are kind of obligated to do IVUS before you treat these lesions, so you understand the reason why the stent closed. Could be under expanded, could be a stent fracture, could be a dissection, could be so many things for stent failure. So the stent was I think undersized. So we decided to, I don't have the pictures of the IVUS, but the stent was clearly undersized and the vessel sized for a 4.0 stent. So we decided to put an onyx. We decided to do an onyx 4.0 stent, 4.0 by 15. So this is our positioning there. So we deploy the stent. I wish I have heard you about protecting this with a wire, but I felt that, well, this is probably unlikely to occlude. And then if it occludes, it's relatively a small branch, and God has given us so many diagonals. So, I mean, that's the concept that many operators argue, not to do anything with the diagonals. So here we did some overlapping inflations, and then we post-dilated this, and now, so then the patient wakes up. He's having chest pain again. The monitor shows ST elevation. So what do we do now?
All right, let's ask Dr. Sandoval.
Yeah, I mean, at this point, there's no going back. Of course, we lost the branch, and now we have to figure out how to rescue. I think, I mean, you can bring a wire and try for a few seconds whether you can get in there, but I would also have a low bar to get like a dual lumen microcatheter, see whether I can park it right next to the origin and scratch at it, and just escalate it. You might sometimes have to go to a little bit more polymer jacketed, Xeon black or something to get at it, but I do think it's a sizable branch, and I think we always struggle in the cath lab. Do we not wire the side branch? At least in my view, it's almost never the wrong answer. Sometimes it's whether we want to do it or not. But of course, at this point, I think we have to rescue that with either quick wire escalation or a dual lumen microcatheter as the next step.
Okay, so we went with, here I put a double bend on a Pilot 200. So I went looking and scratching the stent to see if anything was going to happen. So I'm trying to point to where I have the roadmap on the side. I was trying to see where the branch would be. There was no signs then. I tried IVUS to see if the IVUS would allow me to identify the origin. I was not successful, so trying. So finally keep on trying, and you can see that the branch sometimes will open up. You can maximize your antithrombotic strategy. Sometimes it will show, but here we're very unlucky. The patient is unstable with significant pain. We keep going, change views.
Question, Mauricio, Dr. Cohen.
Yes.
When you did the IVUS,
Mauricio is fine.
Was the first stent distal to the diag, so there's only one layer of stent, or are there two layers now?
So there are in front of the diagonal, and there's one layer. So we can go back to the previous.
No, we don't have to go back. I was just wondering because that also sometimes influences your.
Correct. And that's from the old
fly.
taxes. Remember the old taxes trials that shows that the side branches were occluding at the site of overlap. So, but I think that the stent was right distal.
Yeah, it looked good. I was just checking. But I mean, I think the fact that you intermittently see some flow is promising. And sometimes if you've tried for a while and it's not going to happen, just maybe putting a balloon pump or something for perfusion.
Yeah.
And they often will reopen if you brought them back, because there is a diminishing returns where the more and more aggressive you get, sometimes you can't get it open, but the strategies, dual lumen, polymer wires, different shapes are all things to do for sure.
So finally we got through somewhere. We felt it was a lesion. So we tried a 2.0 balloon, didn't go. We tried a 1.0 balloon. And you can see that thing is not even filling. So then we tried the 1.5 balloon. Then after we try the 1.5 balloon, inflate a little bit, this is what happens. Patients go into VFib, and then we have to shock the patient. So once that happened, look where the wire went. So now we lost a branch, but at least we have a little bit of trickle of flow going to the diagonal. So we were able to get into the diagonal again, balloon it with a 1.5 and then increase to a 2.0. You can see here that the Ikari catheter is a catheter that it's called active support. So we have it very deep seated. So finally we reestablished flow, and we had the TIMI3 flow. So we look again in the other view. We have it's a huge LED that wraps around the apex. The diagonal stayed open. This is his convalescent EKG. You can see there are Q waves across the anterior leads all the way until like before. And this is his EKG the following day. He had a large infarct with large spill of enzymes, and this is his residual echo. So all these patients, there's a toll for STEMIs, and that's why we need to maximize our treatments. So I don't have a conclusion slide, but I felt that we could work together on the conclusions of this case.
Thank you, Dr. Cohen. Wonderful presentation. I think it really highlights a number of key lessons and educational points from the document that apply for any practicing interventional cardiologist. The issue of imaging when you have a prior stent with stent thrombosis, the issue of trying to, if able to do provisional PCI, and this issue of bifurcations. Again, this is an area that I don't know that we have any robust randomized data of bifurcation STEMI and what to do. So this is where document provides some information for the community to fit this to fit in this area. So again, I think we're over time. From what I can see, there's over 100 in the webinar. I see that in X, there's over 300 people join in. So thank you to everybody that took 1 hour to join us and engage with us in the discussion. We invite all of you to go to JSCAI and access the full manuscript that it's now available. This webinar, the recording will be available shortly. And I'm sure at SCAI we can continue the discussions in a number of exciting meetings. Thank you to all of you.
Thank you so much, everybody. Have a great night.